Good afternoon. My name is Dr. Daniel Simon. I'm the Chief Clinical and Scientific Officer of the University Hospitals Health System and the President of University Hospitals Cleveland Medical Center. It's an honor and a privilege to be back with our friends and supporters today for an update on COVID with a special emphasis on equity and health disparities in healthcare. I'm joined today by a fabulous panel of two of my friends, Dr. Lolita McDavid and Dr. Margaret Larkins-Pettigrew. I'd like to introduce both of them to you, and then we'll move forward with our panel discussion. Dr. Lolly McDavid is the Medical Director for Child Advocacy and Protection at University Hospitals Rainbow Babies and Children's Hospital. In this role, she is responsible for community outreach and programming, as well as coordinating the medical services for the Child Protection Unit, serving at-risk children and families in Northeast Ohio. Dr. Margaret Larkins-Pettigrew is an obstetrician and gynecologist, and today serves as the Director for the Center of Equity, Diversity, and Inclusion, and she is also the Edgar B. Jackson Chair of Clinical Excellence and Diversity. Margaret has a broad portfolio driving UH's intentional strategy for equity and inclusion that ranges everything from pipeline to faculty recruitment and retention, as well as special programs in our community related, for instance, to food insecurity. And we'll learn more about that from both of them momentarily. What I'd like to do, as we always do in our conversation, is give you a brief update on the temperature of COVID, where I think we are and where we're going, and then we'll get started. So I usually give you a color, and today it's going to be a little complicated. So Ohio and university hospitals are green. That's the first time I've given a green color of great optimism. However, we have flashing yellow lights around us in the United States. There are 19 states today and Puerto Rico that have markedly increasing rates of COVID infection, hospitalizations, and ICU care. And I'm sure many of you have been hearing about almost full capacity in the Banner Health System, which is responsible for almost 50% of the beds in Arizona. So there's no question that the loosening of social distancing and physical distancing has led to an increase in cases across the United States. The good news is, however, is that Ohio is continuing to do a great job. Although Governor DeWine and Dr. Amy Acton have relaxed our social distancing and have really loosened up many of our activities, both in the hospital and in our neighborhoods, activity of COVID is down across the state. So if we look at our cases, 325 in the last 24 hours is down from a 21-day average of 486. Deaths, we're running 33 a day over the last 21 days, are down to 17. Hospitalizations are flat at about 70. And most importantly, severe cases requiring ICU admission is down to 17 from a running 21-day average of 40. We have also decreased the number of patients in the University Hospitals Health System from only 2 weeks ago, a little mini surge of almost 97 cases across the health system, to today just under 70 patients. So I think we are in good shape. And although things are loosening up in Ohio, people are doing a very good job for the most part of masking, distancing, and being very careful in their interactions. So congratulations to all of our community, and congratulations to you. Well, today we're here for a very important and special topic, and that is the problems that we're seeing in our society related to equity and health disparities. And before we begin that discussion, I'd like to ask both Lolly and Margaret just to talk a little bit about what they do in university hospitals and how they've devoted their careers and their passions to many of these areas. So Lolly, let's start with you, please.
So I'm very involved with the residents and the medical students in their advocacy activities. We are very, very, very lucky to attract people who really want to make a difference. So we've had residents who recently informed our U.S. representatives on the issues that are important to children and getting things into the budget. Our residents have set up a clinic called Haven, and this is for young people who have been sex trafficked and that we've seen through our emergency room here so that they don't get lost to follow up. They are involved in feeding activities, and they just make my heart sing. I also look out and see the people that have come through Rainbow who have continued to make a difference. One was a program officer at the Robert Wood Johnson Foundation, one's at Vanderbilt. So we've trained the next generation of advocates, and that's very important. And we're very involved with the city of Cleveland and some of the suburbs in terms of what goes on for kids. As you know, we're feeding children at Rainbow now every day during the week. We also are feeding at our hospitals. We have food stations. And one of the residents said to me yesterday, she said, you know, it's not a peanut butter and jelly sandwich, it was a chicken sandwich. So we're doing what needs to be done. We know that a lot of our families rely on school-based breakfast and lunch, and so we're trying to stand in the gap with that. We also know that a lot of our kids don't have wideband and they don't have the access to the kinds of computer activities that some other kids do. So we're trying to make sure that kids are not being left behind.
Terrific. So Margaret, an incredible career spanning not only this country, but really around the world. Tell us a little bit about what you do and your passions in this area.
So I guess the title of the office that I head is really where my passion lies, and it's really about community impact, equity, diversity, and inclusion. And within this system, I've had an opportunity to have vision and innovation, which is I'm really so pleased that I really have had opportunity to work internally, designing programs around implicit bias training, really trying to make sure that we are addressing the issues within our institution as it relates to how we give care to both our patients, how we take care of our employees as well, but also how that spills out to the care of our communities. As we think about food for life in our food insecurity areas in the city, looking at expanding our food for life food bank, which is now at Otis Mosque, which is now extending through incorporating both the Women and Children's Center, bringing in high-risk patients as well, and now extending through the total Women and Children's facility. Then to expand that throughout our entire system, only one aspect of that. The issue of pipeline recruitment and promotion of underrepresented minorities to make sure that we have a great team of experts to take care of our community. We've actually been involved in 4 years of a rising 8th grade program, which really brings in our inner city kids to educate them about being physicians and hopefully changing their minds about how they take care of and give equity of care throughout our system. So a multitude of those things that are very, very much involved in trying to make sure that we are not only practicing equity, but also equality, and that we're really addressing the issues that we have right in front of us today as it relates to the pandemic, two pandemics, the pandemic related to COVID, as well as the pandemic of racism that we should probably, I'm sure we're going to address on this call as well.
Great. Well, thank you very much for that introduction. What I'd like to do now to begin to get to that discussion is to just go over some facts related to COVID, which really expose major issues related to health disparities in this country. And that is, as many of you know, despite the fact that African Americans make up less than 15% of the population in many, many states, they're responsible for more than 50 to 60% of admissions and deaths related to COVID. And that's been very difficult for us to face, but it's the facts. And we now have a collision. We have a collision of understanding how do health disparities play into COVID itself, but then most importantly, how are health disparities playing into the underlying issue, which relates to high-risk conditions, heart disease, lung disease, diabetes, are putting our patients at risk, and these are overrepresented in Black and brown individuals. So I know that you think much about this, and the collision of everything related to George Floyd and the horrendous events around that. You know, Marcy and I want to extend we're sorry for what's happening right now. Margaret and Lolly, I apologize for this, and we need to be able to step back, and everybody has to self-reflect, and we have to do more. But I think as caregivers, we're facing in COVID the realization that the outcomes and who is affected is race dependent right now, and we have to address that. So Margaret, let's start with you. I know that you and I talk about this a lot together. Why are African Americans in our community dying at higher rates, and why are they more affected? What's playing on? What's going on here?
So if we talk about in the moment, which hopefully we'll move beyond that, but we talk about in the moment and the fact that, of course, this is the seventh coronavirus that we had that's significantly infectious, that we have many of our clients, many of our employees that are living in crowded spaces. They can't do any safe spacing. Many of the things we hadn't considered before is, how are some of these people living in some of the high rises actually getting masked in order to practice, safe practices related to not being infected. And then the whole issue of trust, which is a big deal, which we discuss all the time, and letting people know that this is something that's very serious, that it is affecting us at significant numbers because of multiple comorbidities, the disparities in healthcare and how we got here with comorbidities that the Black and brown communities have is a whole other issue. So it's all combined. I mean, when you can't deal with the pandemic we're having now around COVID without dealing with structural racism, without looking at the social determinants of health. And so it's all connected. But I do want to say that, we have really thought about this and have been thinking about this for a while. University Hospital has been very involved in First Year Cleveland. So we can't do this by ourselves. As partners with First Year Cleveland, we were the ones that were ringing the bell saying, babies are dying at significant numbers in this community. And we, as not only a system and other systems around us, because that involves everyone, Metro, CCF, we need to come to grips with why are our Black babies dying and not living to be a year of age. And it was that organization that said, let's look beyond just all of these systems that we give great health care. It let university hospitals also lead the way. How do we figure out why we're having so many deaths for our babies and our moms? And so that just translates to what we're seeing right now as far as COVID is concerned. What are we missing here? And that's the thing that we need to really address. What are we missing? What can we now do to pivot into the right direction to make a difference in the lives of these communities?
So Lolly, I know that the governor turned to you. You were added to the governor's council to start addressing some of these issues of social disparities, social determinants of health, and these health disparities. What is your take on this? Is it access to healthcare? Is it comorbidities? Could it be genetic determinants? We heard a lot about ABO and possible other genetic determinants related to the virulence of the virus. What do you think is going on?
Well, I think it's how people live. And actually, Ohio is a very interesting state because it has a large rural population. And we're seeing this affecting in the rural populations that are that are more majority people, but they don't have the access to healthcare. They don't have the access to the grocery stores that we think about when we live where we live. They may be living multi-generational in housing. So you see that. What I try to do is I try to help my residents understand what our families are up against trying to get to care. For instance, I do a thing called Are You As Smart as a Rainbow Parent? It's a PowerPoint that I do with them. And one of my first questions is, can you get from where you live to Rainbow on public transportation? And the hands will go up, yes. Okay, well, how do you do it? Well, I know there's a bus that stops on the corner down by my apartment building. No, if I want to come here on public transportation from my house and I live on a rapid line, I have to walk down to the corner. I have to catch the rapid. If the rapid is going by as I'm walking to the corner, it's another 20 minutes before the next rapid comes. Then I have to get to Shaker Square and I have to cross over and I have to take the 48A bus. If the 48A is pulling away as I'm coming in, then I've got to wait on the next 48A. So now I'm 40 minutes behind. So when your patients may not be on time, they don't have the luxury of getting in a car and coming here. They may have to drop a child off at a sitter or grandma's house so that they can come to their OB appointment or bring the other child to their pediatric appointment. We take our residents when they first start, and we're not going to be able to do it this year. We're going to have to do it virtually. We took them on a tour with Lolly the Trolley. I have no financial interest in Lolly the Trolley. And we take them to see the neighborhoods because I want them to see the strengths that our families come from. When you go into Huff, there's new housing. You know, there is now a venue, a winery in Huff. I want them to see the building that does birthing beautiful babies. I want them to see Fatima Center in Huff with LaJean Ray. I want them to see where the old League Park was. That these families just don't come from a vacuum. They come from a place. And it's really helpful to have people understand that. I grew up in Southwestern Ohio. I rode a school bus every day. My school bus stopped at a trailer park where people lived in trailers with outside plumbing. They were all white. So I know what poor white people are like. But most people who go into medicine, you've only been surrounded by other people who are middle class or upper middle class. And so they may not have that same connection. That's one of those things that I also try to help our families, my residents understand about our families that come from the more rural counties that we take care of here. A lot of them are just surprised. They've never seen this because they grew up in a Beechwood type place or a Shaker Heights or a Avon Lake. And so now they're seeing people who live differently but who look like them. So cultural competence is as important as anything else. You don't have to be from a group to understand the things that those people go up against and what they do to get you. I'm surprised that anybody comes. I have a very good show rate in my clinic, but they come because I have a connection to them. And so I want everybody who trains here to feel like they have that same connection with their patients wherever they end up going. And they go a lot of places. I mean, one of our former residents who's originally from Puerto Rico, she's now practicing in Chicago. And when she comes to town, we always have coffee together and she tells me about what's going on. But she felt that she needed to go back because of her training here and her Spanish language, that she had to serve a population that needed to be served. And so that's one of the things that I try to do. I try to make sure that the people who come through here understand what the mission is and what they owe to families and children.
So Dan,
Terrific.
I just need to make a few comments just to add to what
Sure.
Lolly was saying. One is the issue of access to care. And we know that some people have to come from distances to actually access care. But we can't avoid and ignore the fact that even if they have access to care, many people don't access to care at many of our great institutions. And there's a reason for that. And we get back to that whole trust factor or how we're treated and how people of color are treated when they come into our systems. And so we need to get back to the basics of understanding that people need to be treated equally with equity and to really be given dignity and respect when they come into us as physicians on a day-to-day basis. The other thing that you touched on a little bit was around genetics. You said, is there some component that there's a genetic component to why people are getting COVID? Well, there is no proven genetic component. You know, being Black is not a disease, but there are multiple things that happen in the lives of African American and people of color's lives that really make them more prone to some of the diseases. We talked about some of the comorbidities, but there are ultimately, and immunosuppression, they're more prone to cardiac disease. But this whole issue of weathering and what happens from the time an African American takes a breath in this country and what they're subjected to every single day as far as the toxins that we're exposed to. You know, every single lifestyle of being an African American in this country wears on us. So over a period of time, and there's been lots of studies looking at the length of telomeres and how, you know, the healing and the regeneration and multiplication of cells after you've been through an experience of weathering. And if you think about leaving furniture outside for all season long, what happens to that furniture? At some point, they have to be repaired because that furniture's been weathered. Well, that's what happens internally and physiologically, pathophysiologically, in the lives of African Americans who've been subjected to this weathering concept their entire lives. There's multiple reasons why the African American population is much more prone to become infected with COVID.
Yeah, I think those are, terrific points, Margaret. I think my point was that we know that high blood pressure is a risk for COVID, and there's no question that the prevalence of high blood pressure and the prevalence of uncontrolled high blood pressure is higher in the African American community. And we know that diabetes is a risk factor, and the prevalence of obesity and type 2 diabetes is higher. So there certainly are health reasons. I think there's a lot of things that we don't know yet. For instance, the severity of COVID is worse in men and then in women. And people have questioned, why is that? And then just today, a very large study was published showing that blood type O is protective in COVID infection with a severity of illness that's anywhere from 15 to 20% less compared to blood type A. And we have no idea why that is either. So I think we have a lot to learn, but there's no question, you're right. Access and comorbidities is clearly a big one. Now, this is a question that I want to give to both of you, and obviously is one that we could talk about the whole time. And that is that last week, the Cleveland City Council declared racism as a public health crisis. And as you know, UH supported this measure. Can you explain a bit about what the legislation is getting at, and how can it serve to help our community, and what can we do about it when we say that racism is contributing to a public health crisis? So Lolly, why don't we start with you, and then we'll have Margaret respond.
Well, I'm not quite sure what that statement means. Racism is embedded in the fabric of this country. This country was formed on the slave trade. I mean, all the way back to the Revolutionary War. And so this is not new. What happened to Blacks, what happened to Indians, that was all racism, And so we're talking about 401 years of a way of doing things in this country that we're now telling people we need to do things differently. I think some people think, well, you've had a Black president, so it's all over with now, but it's not. And as we saw with George Floyd, it's not over. And I'm not quite sure what that statement means. I don't know how people want to make that operational. Number one, you got to get some people to believe it. And I'm not sure that everybody believes it. I certainly do. I tell my colleagues in the kind of work that I do that they didn't have to give their children the talk when their children learned to drive. When my children learned to drive, I said, look, if the police want to pull you over, you drive into a spot where there's a light. You keep your hands on the wheel. You say, yes, ma'am, and no, sir. If they ask for your license, ask them if it's okay if you get your wallet out. You didn't have to teach your children that. I had to teach my children that. I was reading an article in the New York Times on Sunday about how people have to, the way that they dress to do jogging. And the other Wes, I'm talking about. Anyway, Wes Moore, he's head of the Robin Hood Foundation in New York. He said he jogs with his polo shirts that say Johns Hopkins on them. So if the police stop him, I'm like, well, why do you think they even know where Johns Hopkins is? But I guess he thinks they do. But somebody else was saying that they run in running clothes that don't identify them as being somebody that somebody's supposed to be afraid of. So when we talk about racism, I mean, it is so embedded in this country. I mean, it's how we started. And so when I see those things, I'm not sure when people put that out there, what do they mean? Because I want to say, what do you mean by racism is an epidemic? Yes, I know that, So it's going to be interesting to see how this plays out. I thought it was very interesting when Dr. Acton made that announcement. We were in a meeting and she made the announcement, and I'm very, very, very impressed with her. But I thought, okay, so now what are you going to do with that, sister? So we'll see.
Margaret, obviously we've talked about this, but labeling it a public health crisis. So that's obviously, that's very strong language, and that means that we have to act. So what does it mean to you? And then maybe I can bridge it to say, okay, what are we going to do about it? What are you going to do about it? And what should UH do about it?
So if we think about what we just talked about, all the comorbidities and what happens to the specific population. Well, we've come to the point when we talk about public health that we understand that what happens to you as a white male also affects what happens to me, and what happens to me also affects what happens to you. And so at the end of the day, we're now seeing significant influences on what happens to us in our economic sphere, in our social sphere, in our environmental sphere. And if we don't come to grips, so we always say that diversity has to make good business sense. We want diversity of innovation and diversity of ideas, and that we want to make people come back to our system because we are good to them. Well, at the end of the day, when we talk about the issue of a public health crisis, we know that if we don't fix the public health crisis, meaning that we have so many comorbidities and we have such utilization of our healthcare system, and that we're not helping people in the preventive aspect. So how do we get to the fact that more African Americans are more prone to COVID? Well, how did they get to have significant hypertension? How did they get to be the number one diabetes? How did they get to, why are they living in places where there are increased, there's a significant amount of food shortage? So when we think about the big picture and the social determinants of health, we need to fix that. We need to think about transportation, housing, and how those policies that were put into place many, many years ago still exist. We can talk a little bit about what happened with George Floyd. Those policies of policing have been around for many, many years. They were put in before Jim Crow. They were put in when we, way before that we can talk about today. And so those policies are what have been difficult to change in order to have a great protective safety service and a accountability of our officers. That's the things we need to change. So if we don't face those things now, because being policed and feeling safe is also part of the big picture of a public health crisis. We need to come to grips with all of that.
Yeah. Well, I think for our friends and supporters who are on the phone, one statistic that always shocks me is that the difference in life expectancy between Huff and Lyndhurst, which is only about 7 miles, is over 22 years. That is a shocking, shocking statistic. That no, this is not a different country. This is not comparing United States to another country. This is the Huff neighborhood to Lyndhurst in our own city is over 22 years. So I think that, UH is trying to address some of those issues. And perhaps, Margaret, you touched on first year Cleveland. You touched on both infant mortality and maternal related complications of pregnancy, including death. Tell us as an example of the Center for Women and Children. So this was the basis of the building, so to speak. And Patty DePompe, Lolly, many others, Aparna Bowl, turned to community advisory groups. We opened a program. Describe a little bit about that program holistically. How is it addressing social determinants and health disparities all sort of in one package? Because after all, we got to put our stake in the ground. We got to do something. So tell us a little bit about that process and what it's done and how can it be reproduced?
I think the first thing we did was we asked the community what they needed. We wanted to figure out what were the barriers to care. Why did they feel they weren't getting the best care possible? And so by doing this needs assessment and not saying, well, we think you need this, but what do you think you need? What do you think will make sure that we are giving you great wraparound care as it relates to care of both women and children? And I think by starting there, we made a significant difference because we listened to the community. Heidi Gartland was right at the top of the tier saying, okay, we need to move this needle, not only at the government level, but at the local level. We need to really figure out what we can do in the communities that we serve. And we took the bold step with Patty leading the helm and really going out and raising the money to say, let's plant this. Let's, like Booker T said, let's drop our buckets in the community where we want to serve and where we want to make a difference in the lives of this community. And let's build something that is inviting. Let's build something that is a green space. and let's build something that we know that they had a part in. So they actually said they helped with the design building. They helped every step of the way. A phenomenal advisory group that included not only lay people, community groups that really came together and said, this is what I think will make the best sense. Aparna Bowl was at the helm of all of this, and I think that is a model for what we need to be doing all over the place. Because to really engage in the community, they have to embrace what we want to commit to them. And that's an example that I think that we should use that model, everywhere we go as far as a system, because that is an ideal demonstration of how we embrace the community and how they embrace us.
Yeah.
So for people who have not been there, number one, the parking is free, which is a huge difference. Okay. We are on the bus line, and then RTA gave us a crossways bus on that. So it's very convenient for people to get there. When you come in, it's very welcoming. The art is wonderful. We have a office that if you need help with how you get your insurance straightened out, there's somebody for that. We have something called Rainbow Connect, and we ask families, do you need different services? And then we make sure that we give them the connection. We have an optometrist there. So if your child is diagnosed with a vision issue, they can be seen there. Pediatric dentistry is on the second floor. The OBGYN is up there. We have a model kitchen and where they teach people how to cook interesting meals. Dave's Supermarket is right behind us, which has been fabulous. I mean, that parking lot is always full. And our families can come be seen. I saw one yesterday where mom was having her postpartum visit and I was seeing the baby, and she only has to come one time now. And then she can go across the street, she can get some groceries and go home. We also have a pharmacy there. So before you'd send the prescription to the pharmacy and then the family had to go to the pharmacy and pick it up. Well, now, by the time we finish giving the baby their vaccinations, it's filled. They go upstairs, they get their prescriptions, and they go home. So it's very, very, very convenient. I think that the people who choose to work there are people who like being in the community and connect with the patients that we see. We also have legal aid. If families are having problems with evictions or substandard housing, we can say to them, you don't have a smoke detector, your landlord has to provide a smoke detector. And you need to ask for that. And this is what you need to ask for. If we see children and their lead levels are high, we can immediately get started on getting the house inspected. So it really is a very unique place. I think where we are is we're in a crosstown place in Cleveland. It's a good place to be. We're neither east nor west. I'm seeing a broader range of patients. I'm seeing many more people from the Asian community that are over like 30th and Payne. They found us. We're having more Spanish-speaking population. We use something called Marty, which is a translator, and we're able to talk to families who speak all kinds of things. Nepalese, we have a couple families that are Nepalese, and we have Marty does the Nepalese thing for us. So I think that the New Women and Children Center is perfect. It could have probably been a little bit bigger. The parking lot could have been a little bit bigger. We did not know that we were going to get the traffic that we get. We also see patients on Saturday mornings in pediatrics, which for our families, you have to understand, a lot of people don't have sick time to take at work. If you work an hourly job at a fast food restaurant, you take off your shift and you don't get paid. If I had to take my children to the doctors, I took my children to the doctors, I dropped them back off at wherever I picked them up, and I'd come back to work and I wasn't dinged for the time. So we've tried very hard to make it as convenient for our families as we possibly can, understanding the things that they're up against, just trying to get healthcare. Healthcare is like way down on the list. And the other thing that happened, and this happened with the COVID, and it's one of the good things, we're doing more telemedicine now. So I was given a list of my patients who have a diagnosis of asthma. And I would sit down and I would call and I would see where they were with their medication. They hadn't been seen in a while. Do you need anything? And we could talk about it. They literally could put the kids onto the phone so I could listen to them breathe, and we could renew their prescriptions. And so they were They just go and get it filled out. They loved it. I had one grandma, she'd been stuck in this house with these kids because school's out. She wanted to talk to me for 45 minutes. And that's okay, I understand. And I listened to her. I'm sorry, Dr. Simon, but I was only allowed to bill for 15 minutes on that visit. But she needed that. And she knew that we were there for her. And I think that what we've learned with COVID and telemedicine is that maybe there's some other ways we can do things that can be even more convenient for our families than what we're doing now.
So, you know, Margaret, you mentioned, and both of you really cast the Center for Women and Children's as really the model of how we go forward. And I think it's important to point out that we brought COVID, ability to evaluate COVID to the Center for Women and Children. So we had testing. There was a really big concern that we were not offering enough testing in this community. And so we brought testing booths and the ability to do nasal swabs at the Center for Women and Children's, the same way we did in Fairfax with Otis Moss. So I guess the question is, and maybe this is a setup, Margaret, for you to talk about food insecurity. So the same things don't apply to adults. They need different things: behavioral health, dementia care, and then food insecurity is a big one. You know, we have patients, I have patients, they make a decision. Do I eat or do I buy my medicine? I can't do both. And so obviously we have to address that. So tell us a little bit about what you're doing, because I think that's a big one. If we can address food insecurity, we can enhance compliance and adherence to medications, blood pressure and diabetes care improves. So tell us, what are you doing about food insecurity? And then talk to us a little bit about food insecurity in our own employees, which was a shocking statistic to me. So perhaps you could answer that.
So we know that there are over 400,000 people living in Cleveland who are live in spaces that are food insecure, that there is not a major grocery store nearby. And so as we looked at our own population and said, you know, how can we really use food as medicine? We really want to make sure that people are being fed, that their families are being fed. And Otis Moss was an ideal place, because this is a place where we completely looked at the model, talked to the community about what they thought they needed, and not only changed the medical model so that we have services built out for that community, like men's health and brain health, and we have Dr. Harwell, who's been there forever, who's still serving that community, but also that we are collaborating with the church in the community, Olivet Institutional Baptist Church, to make sure that that community gets good wraparound care. One of the things that stood out was that that community really was in a place where it was food insecure. And so what we decided to do, with the help of Sodexo and my good friends in that space, is to really build out a food for life market there, where we could actually give food to our clients and to our clients there a week at a time, over a 6-month period of time, to feed a family of 4. So they come in once a month and we give them food for an entire week, and make sure that they are fed and they come back. And as we do that, we're really monitoring their hypertension, their diabetes, their hemoglobin A1C, which is a monitor of the diabetes, as well as triglycerides. We've seen a significant decrease in those values. So we know that food as medicine works. We know that if we feed our patients, who we know have been deemed poor and hungry, that's going to make a difference long term in their health care. Then we look at our employees as well. So we said, well, we're doing this for our patients, but what about our employees? And Peter Protopos, who actually looked at this preliminary data, and found that 30% of our own employees answer those questions as well, to say that they live in food insecure environments as well. So with that said, now we want to really make sure we pivot. Not only are we going to take care of our patients, we want to take care of our employees, especially our frontline employees right now, who are given every day and night, they come in here really taking care of our patients, but they have to take care of themselves and their families as well too. So food for life is something that we will expand throughout our entire system. We know that that is a place where we can make a significant difference, because we have the data that says it will. And that is something that we're expanding. So Otis Moss is a key place. We're doing testing there, and we're making sure we're giving food out.
So Lolly, we're getting a question from our audience about how is UH preparing the next generation of clinicians to effectively address disparities? Your passion is education. How are you doing that?
Well, I'm a pediatrician. And so now in pediatric training, you have to have an advocacy component within your training module. And Dr. Marie Clark, who is a developmental and behavioral pediatrician, she and I work together. She's really taken off on this. We've really gotten our residents involved in legislative advocacy, as well as getting out and getting to know who our patients are and making sure that you understand who they are. You know, when you leave here, this is going to be what you think you need to go do next. I just spoke to one of our fellows who's finishing today, and she's going to Little Rock, Arkansas, which cracked me up because that's my mom's home. And I said, have you lived in Arkansas? I said, they have the biggest cockroaches in the world in Arkansas. But she's looking forward to it, and she realizes that she's going to be working with a different population there, but are going to have a lot of the same issues. Arkansas has a huge obesity problem. And so she's going to be dealing with that. But I think we attract people who want to be change agents. I think we attract people who want to make a difference. And I'm just amazed at the level of the residents that we attract. We have one resident who, well, he's now a fellow in intensive care, in pediatric intensive care. And he was a Marine before he went to medical school. He was a Marine, enlisted Marine, then he came out, he went to college, he went to medical school, and now he's training, and he's just great. And if you met him, and I put you in a room with people and say, who's the Marine, you wouldn't pick him out. And then we have another Med-Peds resident who went to the Citadel and is still in the military. And he is very forceful in his presence, but also with talking to our young male patients at the center about responsibility and looking forward. And they look at somebody who looks like them. I'll use his last name. Last name is Dr. Brown. And they look at people who look like them. And he says, you can do this. You can be anything you want to be. And our patients see that. They understand that. That's why it's so important to have physicians who look like the people they take care of. Because then they say, I can do that. That can be my dream. I have a lot of little ones, and I say, what do you want to be? They want to be a nurse. I say, well, you want to be a nurse practitioner because they work 40 hours and they make a lot of money. But that's wonderful. I mean, for some reason or other, they are attracted to caring. And so I think I'm in pediatrics because this is what I wanted to do. And I could have gone into a different area and made more money, but you know what? You have to get up and want to go do what you got to do every day. And that's what happens for me. So I think that Rainbow, we attract the right type of people for our place. I mean, there are other people who may want to go to some place that's much more high-powered. When I say high-powered, I mean, but then they come here and they realize they're going to get excellent training and then also turn out to be the kind of doctor that we want to send forward to take care of other people.
Terrific. Well, the time is late. We could go on for another hour and we'll have to bring you back. But I want to give both of you a chance to give a little closing 30 seconds. Margaret, we'll start with you. We have a lot on our plate. We have a lot to do. We have a task force now on equity and health disparities. I know you're going to be playing a leadership role in it. Just 30 seconds, final message to our friends and supporters.
So I want to say that, the work is yet to be done, that I have to give a shout out for our centering program. It is top of the line. We're leading the country in our centering programs at Rainbow. And that's also a way that we're teaching a lot of humility through our trainees as well. But our centering program is making significant differences as decreasing forbidding mortality for moms and babes. And that's a model. We have several models across our system that are making a difference. It's about making sure now that they are sustainable and that we're moving toward transformational impact. They're just not programs, that we're really instilling those things that are going to make a difference in all of our lives.
Terrific. Lolly.
Well, I'm looking forward to our final report for the governor's minority strike task force. It's taking a lot of my time. I'm privileged to be asked to do it. It was one of those things where I had shared another white paper report for the State Office of Minority Health, and somebody said, you need to ask her. And so I'm glad. And my job now is to train up the next lollies, the next people to come behind me. If it ends when I leave, then I have no legacy. And so my legacy is the most important thing.
Terrific. Well, I want to thank both of you. It's really been a terrific session. I always learn from both of you, and I'm sure our friends and supporters have as well. What I'd like to do now is just thank them for tuning in. This is a major focus of University Hospitals, clinical activities, research, and education related to diversity and inclusion is a top of mind. We do have a new fund that we put together because everybody is looking for something to do. They want to make a difference. We've had some questions about volunteering. You can contact Barb Nillette in our volunteer office. We will hook you up with Margaret and Lolly for activities related to volunteering. We have endless opportunities across food insecurity, across the Center for Women and Children's, and many others. Margaret has designed a wonderful gender diversity program that we did not have time to talk about today. But uhhospitals.org/equity. For those of you who remain very focused on efforts related to COVID, we still have our COVID caregiver support funds and our community support funds. They've been used, as you know, to accelerate transformational research. Many of you have been hearing about the wonderful results of the Gilead trial with remdesivir. Your dollars help support us enrolling 100 patients in this pivotal remdesivir trial. We just found out from Dr. Bob Salata that we are going to be starting to enroll patients in 2 vaccine trials, one from Moderna and the other from Pfizer. And we are just now embarking on our antibody testing of all frontline healthcare workers and first responders in over 10,000 patients. I want to thank you again for logging on to this Zoom. We look forward to meeting with you every week. We had a few days off there. We're glad to be back. This is a very important topic that collides COVID with very sensitive issues related to racism. We hope this has been helpful, and we look forward to seeing you again. Thank you.
Thank you.
Thank you.